I am Dr. Jim Steele, and my oral poster is titled Bioluminescence Imaging and Digital Planimetry in Stage 4 Pelvic Pressure Injuries. My disclosures are noted. This paper discusses an investigational study that pertains to FDA-approved products cleared for use in wound care. The MolecuLight device is FDA-approved and uses an iPhone platform, currently the OS 12 operating system. The MolecuLight is FDA approved for clinical use. At least 80% of all bacteria produce porphyrins that are heme proteins that can be excited by violet light to fluoresce a red color in the dark. Pseudomonas is slightly different, as the protein is pyoverdin that fluoresces blue or cyan color. This must be done in complete darkness, requiring the dark shroud. The specificity is 100%. This means that there are no false negatives, and all cases who do not have disease are correctly identified. The accuracy for digital planimetry is 5% of the dimension being measured. These patients were domiciled residents of a skilled nursing facility. I would consider these cases high risk. The Charleston Comorbidity Index was over 5, which is the highest category, and this was noted in 4 cases with the highest score of 9. The average age was 80 with a range of 71 to 95. 3 have died, 2 from COVID. Case 1 was a 71-year-old female with a stage 4 chronic sacral wound that had been present for at least 5 years. No treatment had worked so far, but we found that the patient did really well with daily pulsed irrigation of 3 liters at 8 psi over this 5-month period. He then developed low-grade sepsis with detectable smell, slough, malaise, decreased appetite, but no fever. His cardiologist placed him on Xarelto for his history, but not active atrial fibrillation. This caused significant bleeding with irrigation and probably caused the infection. MolecuLight, however, clearly shows a heavy wound and peri-wound bacterial growth in the middle picture. We did not see much of this on the slide on the left. We stopped the Xarelto, resumed the high-setting irrigation, and the high colonization promptly disappears with no red fluorescence. 8 months later, 3 liters of daily irrigation is not enough, and infection seems to recur. There is low-grade slough, increased smell, and a new tunnel has formed in the southeast corner of the wound. Culture reveals Actinobacter baumannii, Pseudomonas, and Strep cloacei. 72 hours of a long weekend, as we do not irrigate on weekends, reveals heavy red imaging in the middle photo. 3 liters of irrigation with the pulse towel irrigator does not clear all the bacteria. We then try something new. We add hypochlorous acid antiseptic to our irrigating solution, and we take a bottle of Anisept and irrigate 100 cc's right out of the bottle through the pulsed irrigator onto the wound. This then dwells for 2 to 3 minutes, and we follow this with a standard 3-liter irrigation, which gives complete removal of red imaging. This is a remarkable and repeatable clinical finding, and I use this combination of Anisept and pulsed irrigation for every wound treatment. This high-risk 95-year-old patient has multiple pelvic pressure injuries, and the lesser one was this ischium, which seemed to be fairly clean, but it acted up over a weekend. The patient now has increasing pain, slough, confusion, temperature of 101, and a white blood cell count of 12,000. Autofluorescence in the middle picture here is impressive. I incised this wound, getting 20 cc's of gross pus. She went to the hospital for consult, but she received only 3 days of vancomycin. The surgeon did not think she was a surgical candidate and sends her back to me to where I have to deal with it. I basically did a local debridement using a Medline disposable curette, and I curetted really the heck out of this wound, getting it as clean as possible, and believe it or not, it worked. A couple of weeks later, the wound irrigation had completely cleaned up the wound, and now at 2 weeks, there is no red autofluorescence, and the wound shows a granulating wound bed. At 6 weeks, we did planimetry, and that revealed a 27 square centimeter wound, which includes the tunnel. I do this by marking the cavity boundaries and inserting a Q-tip and marking the magic marker to get the digital measurements. This is done 2 weeks later, and we see that it drops to 14 square centimeters. This is a 50% reduction, not uncommon in my experience. This patient died of COVID a couple weeks later. This 71-year-old female had a 1-inch draining sinus over the greater trochanter. She had a history of stroke several years before, hemiplegia, COPD, chronic renal failure, and was bedridden. Why was this wound draining a lot of clear drainage? That is the question. This proved to be a periparasitic total joint infection in the sinus tract down to the implants. The 2 images taken seconds apart do not show much fluid coming out of the wound, but autofluorescence clearly shows the dripping serosanguinous fluid that is contaminated with bacteria. It was easy to figure this out once we went back to the medical records and demonstrated that the arthroplasty had been done 5 years before for the broken hip. In my experience, the camera adds terrific imaging capabilities, like you are looking directly at a live wound. This has led to the possibility of doing telemedicine, as the MolecuLight uses encrypted JPEG images. The images clearly guide diagnosis and treatment. I believe the images can be strongly correlated with pathophysiology and clinical parameters. This system has become indispensable in my wound practice. Thank you for your attention.